Hello, my name is Ashley Homrich, and I will be presenting a case study on pleural effusion, intracutaneous fistula, and malnutrition. I will be showing how these can go hand in hand, especially when looking at an intracutaneous fistula and malnutrition. Now, to give this into a webinar format, I wanted to give a disclosure. I am a poor intern, and I am certainly ready to work. Therefore, I really don't have any disclosures. Now, let's move along to my learning objectives. By the end of this presentation, I hope 100% of the audience will be able to define pleural effusion, or maybe they'll just be simply reminded. Again, by the end of the presentation, I hope that 100% will better understand the nutrition guidelines for an intracutaneous fistula. And last, I hope 100% of the audience will feel more comfortable with malnutrition and malnutrition physical assessments via a case study. So as we move along, what is pleural effusion? Pleural effusion is simply fluid buildup between the lungs and chest. Therefore, it's usually a sign or a symptom of a more serious condition. This picture here shows a good representation. As we look to the left, we note a normal lung. We see a membrane which is outlining that lung, and then fluid noted in blue, which is between the membrane and the lung. However, when we look to the right, we can see the pleural effusion. We look to that bottom corner and we see that there is a buildup of fluid. Again, this is pleural effusion. So how common is pleural effusion? It's actually quite common. 1.5 million cases are reported each year in the US alone. And what causes it? There's many causes to pleural effusion. I've given a short, simple list with some of the most common causes, such as cancer, especially noting lung cancer, heart failure, and this is due to the heart no longer pumping correctly and causing a fluid buildup. There is also the more common lung reasons, such as pneumonia and tuberculosis. But how does the patient present when they present with pleural effusion? Usually the only sign or symptom that the patient will present with is shortness of breath. However, the doctor is also able to do a test called percussion. This is when the doctor will hit on the back and listen. They will note that there is a dullness to the sound. Normally, there is a hollow sound with the lungs being open. However, when there is this fluid buildup, that fluid is pressing down and not allowing this hollow sound, noting the dullness sound. So what causes pleural effusion? Or what is the pathophysiology? This simply goes back to Bio 101, or osmosis. It is either too much fluid being created or made, or not enough fluid being removed. There is an imbalance. This can be created in either way or in both. So how is pleural effusion diagnosed? The doctor can simply look at a chest x-ray. Normally, the chest x-ray will show a hollowness or black. However, when pleural effusion presents, there is a white showing the fluid. It can also be noted through a CT scan. This is simply taking the x-rays and combining them, giving a better picture of what is going on inside the body. But nicely, you don't have to cut open the body. We move further along, noting the prevention and treatment. In order to prevent pleural effusion, we must prevent all of those underlying causes. So, we look further to the treatment. The first treatment listed here is thoracentesis. This is taking a needle and removing the fluid. However, sometimes not enough fluid is able to be removed. We then, or the doctors, then move on to the next listed, the thoracostomy. This is taking a tube and removing the fluid via the tube, allowing more fluid to be removed. It is also noted that coagulants may be used as prevention. These are only used as prevention when a blood clot is the underlying cause. It is very important to note that in order to treat pleural effusion, the underlying cause must be treated. For example, if the underlying cause is pneumonia, which is bacterial, then an antibiotic may be prescribed. Similarly, if cancer is the underlying cause, such as lung cancer, the tumor must be treated. Last, we look at the prognosis. This very much depends on that underlying cause. And it is important to note, as with any disease, early treatment is going to give that patient the best outcome or a low rate of complications. So last, we note the medical nutrition therapy. When looking at the medical nutrition therapy, it's mainly focusing on that breathing and the patient eating. Are they able to breathe and sustain being able to eat an oral diet? Oftentimes, it can be hard to intake food if the breathing is being affected. So we want to monitor weight and the intake. We continue to move along, and we will now change our focus to an enterocutaneous fistula. A little bit later, I will be noting how an enterocutaneous fistula and pleural effusion can go together or can work hand in hand. So, how is an enterocutaneous fistula defined? It's simply an unusual connection, and this is the definition of any fistula. But in this case, it is an unusual connection between the GI tract and the skin. This picture shows a good representation of that. It is noted at the top of the right that fecal matter is coming through that abdominal wall. This is unusual. Depending on the exact location, this could be occurring up higher and could lead to aspiration pneumonia. That aspiration pneumonia could then ultimately lead to pleural effusion or to a buildup of fluid. So, how common is an enterocutaneous fistula? It's definitely less common than a pleural effusion, and in many cases, it goes unreported. This may be due to the patient not really being familiar with what is going on or simply being embarrassed. So, what are the numbers? 20,000 patients per year are referred to a specialized treatment center. Again, this is much less than a pleural effusion, which was 1.5 million cases per year in the US alone. Furthermore, and we move along to the classifications of an enterocutaneous fistula. First, where is that abnormal connection occurring? This is the anatomical classification. Next, what is the output? This can be broken down into low, moderate, and high. Low being less than 200 milliliters per day, while high is greater than 500 milliliters per day. And as we would expect, moderate is between the 200 and 500 milliliters per day. Additionally, we look at the etiology, the cause. In many cases, this is due to a post-operative or due to a surgery. They can also occur spontaneous and from trauma. In the case that we will see in a little bit, he presented post-operatively due to a hernia surgery gone wrong. So how is a fistula diagnosed? It can be diagnosed with a CT scan. Again, noting this is taking many x-rays and combining them together. It gives a good representation of what's going on in the body without cutting open the body. This picture shows an intracutaneous fistula. At the top, it is noted with the F in the dark space. This is abnormal, as it should be closed. Furthermore, and less commonly used, a fistulagram may be used. This is simply putting dye into the body and following it, noting when there is an abnormality. So, how does a patient present? Often, the patient will present with a fever due to an infection. Furthermore, and used as a diagnostic tool, the patient may present with fecal matter on a wound dressing. As we would expect, this is abnormal. Fecal matter should not be coming through that abdominal wall, and certainly can be used as a diagnostic tool and as a sign presented. Last, it's important to note that 50 to 90% of cases result in malnutrition. This is especially important to note as we will move into discussing malnutrition in a little bit, and as we will look at our patient in this case. So let's look at the pathophysiology of an intracutaneous fistula, or any fistula. First, it is noted here, the pathophysiology being blood flow. This is because with any fistula, one part of the body is not getting enough blood flow or nutrients and oxygen. It then leaches on to that other area, trying to stay alive. So, how is a fistula prevented or treated? When it comes to the prevention, this is quite difficult, as many cases are caused by trauma or post-surgery. And again, going back to that pathophysiology. Therefore, we look at the treatment. Like the prevention, this is complicated. There are no exact guidelines. This goes back to the classifications. Fistulas can vary greatly with the locations, the output, and the causes. However, it's common for physicians to first try to monitor and hope for spontaneous closure. It is noted here the time associated with various locations. For example, the esophagus and duodenum, they will monitor and hope for that spontaneous closure to occur in 2 to 4 weeks, while the colon, they will only monitor and would expect it to close within 30 to 40 days. Last, the small bowel, they would monitor for at least 40 to 60 days. Other ways of treating the fistula include medications. One exists is protonics. This decreases the gastric acids. Other medications may decrease the motility of the GI tract, trying to ease that GI tract in the symptoms, in the output. Last, surgery may be needed. And this is simply to go in and surgically connect or reconnect the body to how it should be. Last, with the fistula or the intracutaneous fistula, we note the prognosis. It is important to note that before the invention of TPN, a diagnosis automatically meant death. Luckily, today, this is not the case. So this brings us to the MNT, or the medical nutrition therapy. As with any patient, we hope for an oral diet. With these patients, the important things to note with an oral diet are that they are going to need high calories, high salt, and low fiber. The high calories go back to the fecal matter being removed, or not going through the GI tract fully. Therefore, not as many calories are being absorbed as they should be. Similarly, the patients need high salt, as the sodium or any other electrolyte may be coming through or being excreted in an abnormal spot and not being absorbed in the GI tract like it should be. Last, we note the low fiber. This goes back to the GI tract not working properly. Therefore, we want it to be a very tolerable diet. We then move on to enteral nutrition. It's important to note that enteral nutrition may be used with these patients. It all goes back to the location and the output. But if enteral nutrition is the source of nutrition, we want to look to those semi-elemental formulas and elemental formulas, giving them nutrients that are already broken down since their GI tracts are not working properly and are unable to do so themselves. Last, and commonly, parenteral nutrition is often used. This goes back to the GI tract not working properly and them often presenting nutrition. I've given here a caloric and protein needs guideline that was used in a research study or research review. Low output, they note to use 25 to 30 calories per kilogram per day. And for protein, 1.5 to 2 grams per kilogram per day. While high output, you may need as many as 2 times the normal calorie amount and 2 to 2.5 times the normal protein needs. This is due to the fecal matter being removed and nutrients not being absorbed like they should be. It's important to note that up to 75 grams of protein may be lost and not be absorbed like normal. So with that, we move on to malnutrition. Again, remembering that 50 to 90% of those with an enterocutaneous fistula may present with malnutrition. So oftentimes we think of malnutrition being a third world country diagnosis. It's not. And it is important to note that it is right here in Kentucky or Tennessee. So how prevalent is malnutrition? It's noted that 40% of patients in an acute hospital setting may be malnourished. This is due to them not feeling well and not eating well. So, how is malnutrition defined? It is simply defined by an imbalance of nutrition. This definition is important. It shows that even an obese patient can be malnourished because it is just an imbalance of nutrition. It does not mean being underweight. Furthermore, this diagram shows a picture from the consensus from the Aspen and the Academy of Nutrition and Dietetics. Malnutrition may be used in the PES statement. However, it may also be broken down into these 3 categories listed at the bottom: starvation-related malnutrition, chronic disease-related malnutrition, and acute disease or injury-related malnutrition. It's important to note that the starvation malnutrition presents with no inflammation. Therefore, oftentimes in the hospital, it will go back to either a chronic disease-related or an acute-related malnutrition. as there is oftentimes another cause going along with the patient not eating. So when we look at inflammation, we note these markers. It's important to note that malnutrition is no longer diagnosed using albumin or prealbumin. However, we still, again, want to note the inflammation, as we still look at the inflammation for the chronic related and acute related malnutrition. And we want to look at the big picture and not simply one test, as all of these can be affected greatly by things such as hydration status, or in the case of an elevated blood glucose, the underlying cause of diabetes. So again, we note that the diagnostic or the diagnosis is not based on the serum proteins or BMI. However, we note that a BMI or a low BMI or a low percentage of ideal body weight does give us an indication that this patient may need to be evaluated and further looked at for malnutrition. So how is malnutrition diagnosed? It's diagnosed with two of the following criteria. We note that it is diagnosed with insufficient energy intake, or the patient not eating enough or getting enough calories. It is also noted or diagnosed through weight loss, and in a little bit I will show the exact definitions of each of these criteria. Loss of muscle and loss of subcutaneous fat. These can be seen through physically or looking simply at the patient. Fluid accumulation is another criteria. This is simply the edema or the ascites. And, or last, a diminished function status may be used, and this is using hand grip strength. So now we look at a table that is provided or taken from that consensus by the Academy of Nutrition and Dietetics in Aspen, or the American Society for Parenteral and Enteral Nutrition. This table gives concrete diagnostic tools or certain classifications or criteria that must be met in order to diagnose a patient with malnutrition. It is also noted that it breaks it down into acute related versus chronic related. We look at that first category, the energy intake. It is noted that with an acute injury or acute illness related malnutrition, it means, or one of the criteria when it's moderate, means that the patient is eating or getting nutrients less than 75% meeting their energy needs for greater than 7 days. While when it's chronic, it is noted that that 75 or less than 75 is for greater than 1 month. So it's the 7 days versus the 1 month that breaks it down from acute versus the chronic. This is the other half of that table. It's important to note that not every single criteria will present with every single patient. This is why you must have 2 criteria in order to diagnose the patient with malnutrition. And when it comes to the medical nutrition therapy with these patients, it's important to consider the cause of the malnutrition. Why is the patient not eating? The ultimate goal is to get the patients eating or receiving nutrition support. This way, they can have the best outcome or prognosis. So we're going to now move into our case study and see where pleural effusion, intracutaneous fistula, and malnutrition all to come together with this patient. So let's get background to our patient. His initials were JM. He was 80 years old. Again, from he was a male. When we look at his social history, he lived in a nursing home, was a widow, and had 2 sons. He was a long-term smoker. And when noting his family history, his mother died of COPD, so a lung issue or lung condition. His father died from a heart disease. JM presented to his primary care physician as a follow-up to a previous admission. That previous admission had been based on him having pneumonia or aspiration pneumonia. During that visit, the physician noted an abnormality in the groin area and told him that he should report to his primary care physician. During that follow-up, the primary care physician did an assessment or physical assessment of the groin area and noted that fecal matter was coming through onto a wound bandage, and this was occurring abnormally. He was immediately sent to the ER and then onto the acute care hospital, where he was held overnight and for several nights. He was also consulted or sent on to the speech therapist, who conducted a evaluation in which he passed. This order was based on the fact that he had issues previously with an oral diet, and that was due to that aspiration pneumonia. Last, it is important to note the dietitians received a consult, and these consults were based on the BMI being less than or equal to 19 and due to a pressure ulcer. When receiving the consult, the first thing done when assessing the patient was looking at the medical diagnosis. It was noted that the patient was diagnosed with bilateral pleural effusion secondary to CHF, or congestive heart failure. It's also noted that the secondary to or the cause of that bilateral pleural effusion varied depending on the doctor, as another physician noted it was due to the aspiration pneumonia. Regardless, the main medical diagnosis or concern with this visit was the enterocutaneous fistula, or that abnormal connection between the GI tract and the skin. JM's past medical history included a stroke, abnormal heart rhythm, blood clot or blood clots, which led to the chronic use of Coumadin or the coagulant, hypertension or high blood pressure, and again, that pneumonia, which was listed in the most recent visit, and that was underlined or caused by a rib fracture. Past surgical history included a back surgery, left shoulder surgery, hip replacement, and hernia surgery or hernia repair. It's important to note the hernia repair, as this led to that enterocutaneous fistula. The current diet of JM was a cardiac diet. This goes back to the fact that he has a past medical history of hypertension and abnormal heart rhythm. So a cardiac diet includes low sodium or salt, low fat, and low cholesterol. JM's intake or oral intake was still establishing, as he was NPO or nothing by mouth the day before. and the nurse reported less than 50% times one meal was eaten. While it's important to note that the patient stated or reported that he was eating very well. This made it difficult to base malnutrition on the intake, as we will see in a little bit. When looking at the labs, overall, most labs presented in the normal range. However, I noted 4 labs here which were abnormal. The first one being the creatinine, which was 0.66, meaning it was low. And this could be due to low protein intake or simply due to aging, as creatinine does decrease with age. And then the hemoglobin and hematocrit and albumin were also all noted as being low. However, it's hard to fully know the cause of this, as many things can play after with these labs, such as hydration status. The medications that were nutrition related included protonics, which that again goes back to decreasing the gastric acid and helps with the enterocutaneous fistula. Warfarin or Coumadin, which are the same, and that helps with the anticoagulation and helps with that past medical history of blood clots. Antibiotics, which with the fecal matter going into areas that it should not be, this helps with decreasing any chance of infection with the fistula. D5 or dextrose 5 with sodium chloride, which was running at 75 milliliters per hour. And it's important to note that this does provide calories, and in this case it was providing 306 calories per day. The skin, when looking at the skin, although a pressure ulcer was one of the reasons for consultation to the dietitian, it was noted that the only abnormality was the fistula. The I's and O's, or the intake and output, were also noted or assessed, in which it was important especially to note the output, which was 75 milliliters. So this puts it into, or puts JM into the low output category, since it was less than 200 milliliters per day. It was also important to note the past or most previous bowel movement, which was 2 days prior to this assessment. Again, giving an indication that the output was most likely low. So we moved further, noting his height, weight, BMI, ideal body weight, and estimated needs. His height, he was 6 foot 3 inches, or 76 inches. His weight upon this assessment was 137, but it was especially important to note that he had previously weighed 160, and this was only a month previous, and that was during that admission for the pneumonia. Taking that weight divided by the height, and then dividing that again by the height, and timesing it by 703, gave us a BMI of 16.7, indicating that JM was underweight, as this was below 18.5. And ideal body weight, he was only 68% of his ideal body weight. So while again malnutrition is not diagnosed with the BMI or the ideal body weight, the fact that his BMI was low and his ideal body weight was low, it gave a good indication that this patient may be malnourished and needed further assessment, as well as looking at that weight history of going from 160 to 137 in just 1 month. The estimated needs for this patient were calculated using Mifflin St. Jeor and timesing it by a stress factor and an activity factor. This gave 2,150 to 2,350 calories, which seems within a reasonable range with the fact that he was 6 foot 3 inches. The estimated protein needs were also calculated, and at the time this was based kind of on a wound factor, so giving a 1.2 gram protein per kilogram. So it's important to note that this certainly could have went up in the amount, and protein could have been calculated using a 1.5 to 2 gram protein per kilogram factor. A physical assessment was also noted or completed with this patient. So the hand grip test used, as well as just simply noting any abnormalities to the physical signs that were presented. The hand grip test was completed 3 times, and his arm was held away from his body. This way it could not give any leverage, or his body could not give any leverage to that result. The average came to 5.2, indicating he was severely reduced in his physical function or hand grip strength. It was also noted, and can be seen here in this picture, and I will note that this was not my patient, but is simply a picture that gave a similar representation to what I saw, and it was found on the internet. The patient presented with sunken in area around the eyes and in the cheekbone, noting that indicating that there was subcutaneous fat loss. Along with all of the information which was previously noted, this blurb was included into the dietitian's assessment. So it simply just is stating or reiterating again that the patient was consulted to the dietitian based on his low BMI and a pressure ulcer, which turned out to be the enterocutaneous fistula. Additionally, the patient JM had passed his speech eval the day before, and he had been nothing by mouth the day before as well. The nurse was reporting that he was eating poorly with less than 50% times 1 meal, while the patient was reporting that he was eating very well. And based on this conflict on is the patient eating well or is he not, a malnutrition physical assessment was completed. So it was noted that there was fat loss in the orbital region or the eye region, in the temporal region or near the temples, that side part of the face at the top, and the buccal region, and that's just a fancy way of saying in the cheek region. Hand grip again was tested, and this was tested using an average of 3 times, and that gave a 5.2 result, and this is noted to be severely reduced. This blurb also includes intervention, which we'll go on into in a little bit. So next we move on into the nutrition diagnosis with this patient. The diagnoses that were used were malnutrition related to clinical condition, or more specifically to that enterocutaneous fistula. And this was evidenced by a 14% unintentional weight loss. So it was going from the 160 to the 137 pounds, and that was in approximately 1 month. The mild subcutaneous fat loss was also an indication for that malnutrition. So noting that fat loss in the eye region, in the temporal region, and in the cheek area. Last, it was noted through the reduced grip strength, and that was the average of a 5.2, which indicated severely reduced. The other nutrition diagnoses that was included was the increased protein needs related to skin integrity, as evidenced by the enterocutaneous fistula. So again, we note the fact that up to 75 grams of protein can be lost abnormally through that fistula. So the protein needs are going to be much higher for these patients, which again goes back to the factor of 1.5 to 2 grams per kilogram needed for the low output patients and the greater than 2 needed for the high patients. This is in comparison to the normal patient who needs about 0.8 or 1 gram of protein per kilogram. We continue with the A-dime, so we now move on into JM's intervention, or the intervention that was done with JM. First, it was important just to simply make sure that the patient did feel that he could eat an oral diet and that he felt safe swallowing. And this was just simply based on the fact that with his previous admission, he was not able to eat an oral diet and the need for a swallowy valve. He indicated that he felt perfectly safe with an oral diet. Furthermore, the cardiac diet was still continued. However, it's especially important to note that looking back on this case, it would have been better to change this diet to a regular diet. While yes, JM does have a past medical history of hypertension, the issue at hand was that enterocutaneous fistula. So looking back at that physiology and abnormality with the fistula, it's again noted that electrolytes may be lost, which are normally absorbed. So there is a need for a high sodium diet. Other simple interventions included just encouraging JM to eat an oral diet. He stated that he would. And last, Juven was added. This was added twice a day, and this was to give him incomplete protein to help with that wound healing, and to give him glutamine, which is noted to help with nitrogen balance, as it's common for patients with enterocutaneous fistulas to have a negative nitrogen balance. It's also noted that a multivitamin was added by the physician and certainly would be a recommendation that the dietitian would give. And this again goes back to similarly with the electrolytes being lost, it wouldn't be uncommon for vitamins and nutrients to be lost in that fecal matter and not absorbed like normal. It's also noted that other interventions that were attempted but were not successful were just simply trying to add Ensure, Boost, Mighty Shake, or any oral supplement at all. This would give the patient JM more calories. However, he did refuse all supplements. So monitoring and evaluating. These are the things that we kept a close eye on. So noting the total energy intake, the amount of food, and the total protein. And we wanted to keep a close eye on this as, again, the nurse indicated that he was eating poorly, less than 50% times that one meal, while the patient was reporting that he was eating well. So it was important to monitor and evaluate and figure out exactly how is he eating. Additionally, weights were monitored, and this goes back to the fact that his BMI was underweight. It was under the 18.5, and his ideal body weight percentage was also low. So the goal with this is that we want a healthful weight gain with no significant changes. So increasing the weight slowly. Many follow-ups were conducted with this patient. The very first follow-up came the next day when the pharmacist reported that the patient was on TPN, or total parenteral nutrition, so being fed straight through the vein and bypassing the GI tract. With this, the pharmacist had chosen a solution and a rate of dextrose 25, 5% amino acids, goal rate being 66 milliliters per hour, and then lipids being added twice a week. It's important to note that the lipids being added twice a week was only based on a thought of there being a shortage and that this patient was a floor patient. They were not an ICU patient. So at this rate, with this solution, 1,806 calories and then 79 grams of protein were being provided. This was substantially lower than the estimated needs, which were previously given. Again, that was 2,150 to 2,350 calories. And noting that extra protein is needed for these patients with the fact of trying to promote wound healing and up to 75 grams of protein being lost through the fistula or in that fecal matter and not being absorbed properly. When looking at the surgical notes, it wasn't completely clear why the TPN was indicated, but it appeared that it may be due to plans for surgery and to give the bowel a rest. With the follow-up, a new nutrition diagnosis had to be added. So in this case, it was inadequate oral intake related to clinical condition and enterocutaneous fistula, as evidenced by NPO or nothing by mouth and need for nutrition support. So again, this was an additional nutrition diagnosis. The diagnoses of malnutrition and increased protein needs remained as well. The intervention was the TPN, which was modified, and it was increased to 70 milliliters per hour. So again, that was D25 or dextrose 25, 5% amino acids at 70 milliliters per hour. And then the lipids were changed from twice a week to daily. And this gave 22% of the calories coming from lipids, which was a good amount because research indicates not to give any more than 30% with these patients. This solution at this rate provided 2,264 calories and 84 grams of protein. So it gave calories and protein closer to or within that range of estimated needs. Additionally, the glucose utilization rate was calculated, and that gave a 4.7 milligrams per kilogram per minute dextrose, and This was within an acceptable range since it was between the 4 and 6. And we take note with this because we want to make sure that the patients aren't going into hyperglycemia or high blood glucose, and should be monitored with any patient. So now with the patient being on TPN, the monitoring and evaluating of this patient changed slightly. First, we're going to monitor the TPN solution and rate, making sure whenever visiting this patient that the correct solution is hung and that the rate is going at the correct rate, the rate that is ordered and the rate that is in the computer, and that it is being increased at an appropriate amount. Additionally, the electrolytes were now being monitored, especially looking at potassium, phosphorus, and magnesium. And this goes back to the patient being malnourished or having poor intake previous to admission. This patient was now at risk for refeeding syndrome, and there could be an imbalance of electrolytes and fluid, which could certainly lead to death. Therefore, it was especially important to monitor those electrolytes, again, the potassium, the phosphorus, and the magnesium, and replacing them as needed. Additionally, with this patient now being on lipids, the triglyceride was monitored more closely, making sure that it was less than 400 milligrams per deciliter. And it's noted that this patient was within good range of that goal, with the triglyceride being much lower than the 400. Last, and as previously discussed with monitoring and evaluating this patient, we looked at the weights, and this was a healthful weight gain with no significant weight changes. This came to about a half a pound to 1 pound per week with this patient. And with the no significant weight changes, the goal is for less than 5% weight change in approximately 1 month. Just to give a short overview, this patient, JM, was off of TPN within 5 days. Therefore, it could certainly be debated whether or not TPN was indicated for this patient, and we would not want to simply put the patient on TPN only because of their malnutrition. However, we will note the fact that this is the shortest amount of time frame deemed acceptable for TPN. After being off of TPN and while weaning the patient off of TPN, he was placed on a regular diet, which again was a good call and certainly needed, as the patient would want to consume a high calorie and high sodium diet. He was also placed on Temegase, which is an appetite stimulant, and certainly indicated with his diagnoses of malnutrition. JM gained 2 pounds, and this was a 1.5% change over 9 days. This may be at a slightly high rate, and would certainly want to continue monitoring if this patient was to remain in the hospital for a longer period of stay. The 1.5 in 9 days does put him on track to have a weight change percentage of 5% in 1 month. So certainly in considering that significant weight change. His hand grip overall certainly improved. It went from a 5.2 to a 17.6, and this moved him from a severely reduced grip strength to a moderately reduced grip strength. So this certainly indicates that the nutrition status was improving. And last, as previously stated, the triglyceride and electrolytes were well managed and they were within normal range upon follow-ups. In summary, again, just reminding you of the definition of pleural effusion. Pleural effusion is a buildup of fluid around the lungs and can greatly affect the breathing of a patient, which then can affect the oral intake of a patient. There is no cookie cutter nutritional guidelines for enterocutaneous fistulas. We do want to note that. There's simply just the guidelines based on reviews and research, and it certainly depends on where the fistula is located and how much output is caused by that fistula or that abnormality. And last, malnutrition is still an area that is highly being studied, and it no longer applies to third world countries. So I thank you for listening to my presentation, and I now just present you simply with the references.